Welcome to The Explainer. If you're a medical trainee trying to get a solid grasp on multiple sclerosis for the wards or for your boards, you've come to the right spot. We're going to break down this really complex topic into the must-know, high-yield points you need to have locked in.
So to really get a handle on MS, we got to start at the very beginning. What is actually happening inside the brain and spinal cord? And who's at risk for developing this thing?
Okay, so what it really boils down to is this. MS is an autoimmune disease. Your own immune system gets confused and, for some reason, decides to attack the central nervous system. I want you to think of the myelin sheath around your nerves like the plastic insulation on an electrical wire. In MS, the immune system just starts stripping away that insulation. And when that happens, the nerve signals basically short circuit. That's why patients get such a wild, unpredictable range of symptoms.
So what pulls the trigger? Well, it's not just one thing. It's this perfect storm of genetics and environment. On the genetic side, you absolutely have to remember the HLA-DRB1 times 15 allele for your exams. That's a classic. But, that just kind of loads the gun. It's the environmental factors that seem to fire it. Things like low vitamin D, which we know helps regulate the immune system, or having had an Epstein-Barr virus infection in the past. Then you throw smoking and obesity into the mix, and you can see how this risk profile starts to build up.
The whole disease process really follows this devastating four-step cascade. First, you get these rogue T cells that manage to sneak across the blood-brain barrier. Once they're inside the CNS, they basically call in for backup, B cells and other inflammatory soldiers. And this sparks this intense inflammation that forms what we call plaques. This inflammatory firestorm doesn't just damage the myelin, it kills the very cells that make it, the oligodendrocytes. And that final step, degeneration, that's the real problem. That's where you get permanent nerve loss and scarring, and that's what leads to lasting disability.
Now, the thing is, this underlying process, it doesn't look the same in every patient. So let's talk about the different ways MS can show up, the different clinical patterns or phenotypes it can take.
It is so important to get these types straight because they really tell you about the patient's likely journey. The vast majority of people, something like 90%, start out with what we call a relapsing remitting course. They have these attacks or relapses, but then they get better. That very first attack, by the way, is called a clinically isolated syndrome, or CIS. Now, the big worry with RRMS is that about half of those patients will eventually transition to secondary progressive MS, and that's when the disability starts to build up without those recovery periods. And then there's a smaller group, maybe 10%, who just have this slow, steady worsening from day one. We call that primary progressive MS. All right, let's do a quick run-through of some classic presentations. If a young patient, especially a woman, walks into your clinic complaining of painful vision loss in one eye, and they tell you that colors just look washed out or faded, MS-related optic neuritis has to be right at the top of your list.
Next up, a total classic brainstem sign, internuclear ophthalmoplegia, or INO. This happens when a lesion zaps a specific nerve highway called the medial longitudinal fasciculus, the MLF, which coordinates your eyes moving together. Now here's the key. If you see this happening in both eyes in a young patient, MS shoots to the very top of your differential. It is almost pathognomonic.
And here's another one you'll hear about. A patient describes this bizarre electric shock sensation that zips down their back and into their arms or legs whenever they bend their neck forward. That is Lermet's sign, and it points you directly to a lesion in the dorsal columns of the cervical spine. And let me give you a super high-yield pearl for your exams. Look, unilateral trigeminal neuralgia is pretty common in older folks, but if you see it in both sides of the face, especially in a younger person, that is a massive red flag for an MS plaque messing with the trigeminal nerve root in the brainstem. Okay, so you've got the clinical picture. You're suspicious of MS, but how do you actually prove it? This is where we need to get objective. We use specific criteria and, most importantly, imaging to lock in the diagnosis. So to officially diagnose MS, we use something called the McDonald criteria. And the entire goal of this framework, the whole point, is to prove one simple concept, that the damage is happening in different places in the central nervous system and at different points in time. We call this dissemination in space and time. The modern McDonald criteria really give us a roadmap. First, you need to show dissemination in space. That means finding lesions in at least 2 of those classic MS hotspots. Then you need dissemination in time. You need proof that new stuff is happening over time. And this last part is absolutely crucial. You have to ask yourself, is there any other possible diagnosis that could explain this whole picture better? You have to rule out the mimics.
And this is where the MRI is just so unbelievably powerful. A single scan can tell a story across time. See, an active lesion, a new spot of inflammation, will light up with gadolinium contrast. But an old, non-enhancing lesion is like a scar. It's just dark. So think about it. If you see both a brand new enhancing lesion and an old, non-enhancing one on the exact same MRI scan, boom, you've just proven dissemination in time, right there with a single picture. It's incredible. Now, when you're looking at an MRI report, these are the buzzwords you need to be on the lookout for. Dawson's fingers are the most famous. They look like these little fingers pointing out from the ventricles, and they follow the path of tiny veins. T1 black holes are more serious. They represent spots of permanent nerve loss. And a newer finding to keep an eye on is the central vein sign, which turns out to be highly specific for MS.
But hold on. Before you stamp that chart with an MS diagnosis, you've got to play detective for a minute. You have to consider other diseases that can look and act a whole lot like MS. This table right here is absolute gold for your exams. You have to know how to tell MS apart from its two main mimics, NMOSD and MOGAD. And let me tell you, this isn't just academic. Giving an MS drug to a patient with NMOSD can actually make them much, much worse. The key really comes down to testing for specific antibodies, AQP4 for NMOSD and MOG for MOGAD. And clinically, you should be suspicious if the optic neuritis or the spinal cord lesions seem unusually severe, or if they're happening in both eyes or extend over a long segment of the cord.
Okay, let's switch gears and talk about management. We can really break this down into two main buckets: treating the acute attacks, and then the long-term therapies that we use to change the course of the disease.
When a patient is having an acute flare-up that's causing them significant problems, the algorithm is pretty straightforward. You hit them hard and fast with a short course of high-dose IV steroids. The goal here is to quickly cool down that inflammation. Now, if that doesn't work, especially in a really severe attack, you can move on to plasma exchange, or PLEX. Now, the real game changer in MS care over the last couple of decades has been the development of disease-modifying therapies, or DMTs. The whole treatment landscape has evolved. We started with older, less potent injectables, then moved to more convenient oral pills, and now we have these incredibly effective monoclonal antibodies. But as you can see, there's a trade-off. While the monoclonals are our biggest guns for stopping relapses, they also carry more significant risks, like the rare but devastating brain infection called PML, which is a major concern with drugs like natalizumab. All right, let's start to wrap this up by summarizing some key prognostic factors and hitting a few more rapid-fire pearls to really lock this all in. When you're sitting down and talking with your patients, it's really helpful to know about these prognostic factors. Things like being male, being older at diagnosis, or having early motor symptoms, these can all signal a more aggressive disease course. And knowing that might help you decide to be more aggressive with therapy earlier on. You have to remember Uthhoff's phenomenon. It's a total classic. This is when a patient's MS symptoms get temporarily worse when their body temperature goes up, like when they exercise or take a hot shower. The key thing to understand is that this is not a new relapse. There's no new inflammation or damage. It's just a temporary effect of heat messing with the conduction on those already damaged nerves. And all of this really brings us to the big million-dollar question for the future of MS care. Look, we've gotten really, really good at stopping the inflammatory relapses. But the next great frontier, the real challenge, is figuring out how to stop that slow, steady, smoldering progression of disability that can happen even without attacks. Will our increasingly targeted therapies finally be able to halt the neurodegeneration itself? That is the challenge that lies ahead.